Aloha, everyone. I'm Angela Petersons, and I'd like to welcome you to the American Lung Association in Hawaii's Community Connections. Today, we will be discussing advances in lung cancer screening and treatment presented by series sponsor Aloha Care and event sponsor Genentech. Before we get started, I'd like to go over a few housekeeping items. Today's webinar is being recorded and will be available for future viewing. We will send a link to the webinar once it is ready. We will take questions after each of our speakers. You can ask your questions by using the Q&A feature on the lower part of your Zoom screen. And now, please welcome American Lung Association in Hawaii's Executive Director, Pedro Haro.
Thank you so much, Angela. Aloha, everybody. Welcome to our Community Connections. It is Lung Cancer Awareness Month. And so today we'll be talking about a subject that is in a lot of people's minds this month, lung cancer, and what is newly available for its treatment and diagnosis. What we know in what we are still to come. Having a little bit of technical difficulties. There we go. But before we get started, I'd like to thank our sponsors for today's presentation, our series sponsor, Aloha Care Insurance, and our event sponsors, Genentech. We would not be able to do this without their support, and we're truly grateful for their investment in lung health of the people of Hawaii. We'd also like to thank our volunteer leadership board, headed by Dr. Cynthia Goto, for their assistance. We are very grateful for our Lung Force Women's Cabinet and the Young Leaders Cabinet, who assist in raising awareness of lung cancer and prevention of lung disease. Today's objectives will focus on advances that we have made on lung cancer screening and treatment. We have two fantastic speakers who can talk about their perspective of revolutionary work that we all get to benefit from. To start things off, we'll have Dr. Taryne Imai from the Queen's Health System, who will talk about her work using robotics to shorten the time of diagnosis and treatment of lung cancer. After a question and answer with Dr. Imai, we will hear from J.B. Smith, and she'll talk about biomarker testing, which is a way to look for genes, proteins, and other substances called biomarkers that can provide information about lung cancer to treat it more successfully. J.B. will then answer your questions. I also wanted to give you a quick reminder of who we are and what we do as a lung association. So launched in 1904 in the continental US, the American Lung Association has been in Hawaii since 1924, when it was launched by Isabel Mabel Wilcox of Kauai to deal with the tuberculosis pandemic, which was killing many Native Hawaiians at the time. Since then, we have developed 4 strategic imperatives as an organization. They are to defeat lung cancer, champion clean air for all, create a tobacco-free future, and improve the quality of life for those with lung disease and their families. In the year 2020, we expanded to include the ending of COVID-19, the largest lung health pandemic of our lifetime. We accomplished our strategic imperatives by employing education and advocacy programs that are rooted in research. And as part of that research that we conduct, we work on 4 signature reports each year that track the progress that states have made in improving lung health. Just yesterday, we released our annual State of Lung Cancer report, which identifies state-specific information around the way states can best focus their resources to decrease the toll of lung cancer. The results for Hawaii were mixed. It was a bag of important advances, but lagging a great deal in some markers. I'm going to show you a little bit of that. First and foremost, it's important to celebrate that Hawaii has one of the lowest rates of new lung cancer cases in the nation. This is probably due to the fact that we have one of the lowest smoking rates in the nation as well. And the cases have continued to decrease year over year. But it's also important to know that lung cancer continues to be the #1 cancer killer of both men and women in Hawaii, killing more people in Hawaii than breast, prostate, and colorectal cancer combined. In fact, most people who end up being diagnosed for lung cancer in Hawaii will ultimately die from the disease. And a big reason for that could be that less than 3% of the people at high risk of lung cancer in Hawaii actually receive a low-dose CT scan, which is the way to do an early screening of lung cancer. Our report found that only about 20% of the people who are diagnosed with lung cancer are diagnosed in an early state. People in early stage of lung cancer have a 63% chance of survival, but those chances diminish incredibly as the stages advance. This places Hawaii last in the nation for early diagnosis of lung cancer. And many people will ask, well, why is that? And to be honest, we don't know. That is why the American Lung Association pushed for the creation of the Early Lung Cancer Screening Task Force and was able to pass a legislative act in 2022 to determine the root causes of why Hawaii does so terrible with early diagnosis. The task force will have a preliminary report in the next few weeks and then a final report in 2024. On a bright note, we have improved early diagnosis of lung cancer by 1/3 in the last 5 years, which is exactly the type of trend that we want to see happening. And while Hawaii still lags compared to the national average for the rate of 5-year survival, we are also trending in the right direction. For the first time in several years, we are finally seeing improvements in the survival rates with an overall increase of over 20% in the 5-year survival rate for people with lung cancer. This is brand new data that I hadn't talked about in public yet. You are the first people, other than the people who read the report yesterday, who are hearing about this. This is incredibly fantastic trending information. For those of you who have been in this journey with us to defeat lung cancer in Hawaii, this is truly something to celebrate. And what's also fantastic to celebrate is that Hawaii has seen the return of one of our best and brightest, and one of our presenters today, Dr. Taryne Imai. Dr. Imai is the Program Director of Thoracic Surgery for the Queen's University Medical Group, affiliated with the University of Hawaii. She was previously the Clinical Chief of the Division of Thoracic Surgery at Cedars-Sinai Medical Center in Los Angeles, California. She's originally from Honolulu, and she completed her undergraduate and medical school education at the University of Hawaii at Manoa. After completing general surgery residency at Harbor UCLA Medical Center, she went on to complete fellowships in thoracic surgery at the University of Pittsburgh and surgical critical care at Cedars-Sinai Medical Center, and completed her master's in education for health professions from Johns Hopkins University. Dr. Imai's clinical practice specializes in robotic approaches in the treatment of benign and malignant diseases of the chest. In 2019, she was awarded the Women in Thoracic Surgery Intuitive Robotic Fellowship in Advanced Robotic Training. Please help me welcome Dr. Taryne Imai. Dr. Imai, I'll turn it over to you.
Okay. All right. Can you hear me?
Yes, we can hear
Okay,
you.
wonderful. Thank you so much, Pedro, for the introduction, and thank you to the ALA for allowing me the opportunity to present today. I'm really excited about what we're going to share in the next half an hour, and I hope you are too. Let's see. Okay. So as Pedro was saying, I'm at Queens. I just returned home last year, so I've been at Queens for a little over a year now. It's been an incredibly busy year, but it's been wonderful, and I think the work that we're doing is really impactful. So the objectives that we'll go over in today's presentation. First, we'll sort of discuss why robotic navigation or bronchoscopy is a much needed technology, and how this technology is actually a game changer for us in terms of increasing our detection rates of early stage lung cancer. Next, we'll go on to our institutional experience here at Queens with our ION program that we launched over the last year, and then quickly go over some future directions of early stage lung cancer detection in Hawaii. So the story starts off with discussing about what the pulmonary nodule is. So a pulmonary nodule is a growth in the lung that is less than 3 centimeters in size. Now, the incidence of pulmonary nodules have been increasing just due to the widespread adoption of CT scans. And this is CT scans that are done for coronary CT scans to look for cardiac disease, ER CT scans, mainly, anyone that walks into an emergency room these days will get a CT scan. And of course, the COVID pandemic, which many patients with COVID actually got chest CT scans to evaluate their infection. There's an estimated 1.5 million pulmonary nodules that are expected to be detected in the United States annually. And with widespread adoption of lung cancer screening programs, this number is only going to be expected to increase in the next coming years. And although the majority of these nodules will only require surveillance imaging, many will actually require biopsy. And why the pulmonary nodule relates to lung cancer is that we know that with lung cancer, early detection does matter. And many of these pulmonary nodules, although they may be benign, many of them will actually be early stage lung cancers. And we actually may have an opportunity to now intervene. And with so lung cancer is the most deadliest cancer we have out there in both men and women. However, when detected early, the 5-year survival is actually relatively high. And the group that we want to look at here is the stage 1 group. So if we can detect a lung cancer that is less than 1 centimeter in size, that patient actually has a 5-year survival of 92%. As you can see, as that nodule or that lung cancer grows by centimeter, that 5-year survival actually starts plummeting. And when that cancer is actually 2 to 3 centimeters in size, our 5-year survival drops from 92% to now 77%. So it's really imperative for us to actually diagnose lung cancers at earlier stages and smaller sizes in order to sort of optimize that 5-year survival in our patients. But the challenge is actually diagnosing these pulmonary nodules and diagnosing these cancers. Now, the traditional approaches for biopsy have been CT-guided biopsy, which is done by a radiologist, and that essentially biopsies the nodule from the outside in, meaning a needle gets stuck through the chest wall and into the lung. Now, the diagnostic yield of this procedure is pretty high. It's about 71%, meaning 71% of the time you can nail down a diagnosis of cancer or something that's benign in these nodules. However, if you can imagine just the invasiveness of this procedure, there is a high complication rate. So about 1/3 of patients will actually have a collapsed lung and 1/3 will actually have bleeding. Now, the second approach is bronchoscopic biopsy, which biopsies these lung nodules from the inside out. And although it's much safer because you're actually not sticking a needle through the chest wall and it's a bit less invasive with a lower lung collapse rate and bleeding rate, the diagnostic yields on this is often poor. And honestly, it's almost a flip of a coin whether you get a diagnosis from this biopsy or not. And so what we have now in 2023 is robotic technology. And what we're going to talk about is our robotic navigational bronchoscopy system. We use the Ion by Intuitive here at Queens, as well as what I used at Cedars. And these are some of the advantages of this platform. So one, this platform actually allows us to more precisely maneuver out into the periphery of the lung. And because it's robotics and it's not dependent on sort of us driving the scope, there is greater stability and accuracy. The small working channel is about 2 millimeters, and therefore we can actually pass in a very small fiber optic camera, and it allows us to actually see way out into the periphery of the lung under direct visualization, which we'll see in a moment. The shape sensing technology allows for stability, meaning it locks in place once the target is reached. So as we're passing biopsy tools, the catheter does not move. It allows us to create these anatomy borders. So we know exactly where the outside of the lung is, where the blood vessels are. And that's why it's actually a safer procedure. And overall, it's just easier for us to, as far as the operator goes, it's a lot more ergonomic for us. So this is a video of what robotic navigational bronchoscopy looks like. Let's see. So I'm at the console here on the side, separate from the patient, driving the camera. The robot is actually docked to the breathing tube of the patient, and this is the interface we see. So on the left side, this is a 3D virtual reconstruction of a patient's CT scan that the software sort of produces. And it produces this blue line, which is the cookie crumb path that helps me sort of navigate to where this nodule is. The image on the right side is actually the real-time image of what we see in the camera. And although it's a 2 millimeter camera, the visualization is actually very, very clear. And as we can drive out more and more, and when that camera clears up, we're pretty far out into the lung, but we can actually now see this nodule that we're about to biopsy. And that's why our diagnostic yields are so high with this technology, because we actually can see what we're now biopsying really far out into the lung. And that's why the accuracy is unprecedented. So we can really change the culture on how we manage lung nodules. And the opportunity here is really to decrease that population of watchful waiters. Those patients that have lung nodules that may have been told, okay, let's keep watching it and monitoring it with serial imaging. We now don't necessarily have to keep watching, and we can actually intervene. We can actually biopsy these nodules with a very high diagnostic yield and offer patients either peace of mind, or if they have a cancer, now an action plan and a hope in actually increasing the early detection of lung cancer. So this is our robotic navigational bronchoscopy experience here at Queens over the last year. So launching a ion robotic navigation bronchoscopy program is a true multidisciplinary effort. It really does take a village. We partner with not only thoracic surgery and interventional pulmonology, but we really need to really key in our pathologists who are actually reading our specimens, our anesthesiologists who help us ensure that the patients are safe and put to sleep okay. Radiology, because we do depend on these very fine cut CT scans in order for us to put that into the software and generate those 3D virtual images. And then, of course, our staff on the front lines in the OR, as well as our hospital and department administration and leadership in order to gain their support to really get these programs pushed through. And so this is our timeline at Queens for our R&D program. So in April of 2022, I was actually still at Cedars, and this is when the Queens team actually, we had first contact, and they actually came to one of the conferences to kind of learn more about this technology. So this is me still at Cedars doing these procedures. I then started at Queens in September of 2022, and in September, the Queens team actually went over to California for training on this new platform. We then launched our program 1 month later in October of 2022. And then on the bottom, this is our current day. So this is myself with Dr. Brad Tokeshi, who's my partner in crime in our program here at Queens. And after 1 year of launch, these are some of the milestones we've hit in the last year. So we are the #1 program out of 48 new programs that were launched in the last year. Currently, we're #8 for the highest volume in the Western region. And we are currently, even though we're a new program, we're at already #57 out of 500 programs in the country. In the last 6 months, our diagnostic yield has been 94%, which is one of the highest yields that we have in the country. So although Hawaii is a small state, I say we're small but mighty, we are definitely making our footprint in the world of early detection of lung cancer, not only with our state, but within the country as well. So in the last year or so, we've done this procedure on 195 patients. And this is a run from our launch in October of 2022 to August of 2023. The mean age of our patient population was 71 years old, and most of our patients were former smokers. Our diagnostic yield for our overall program is 92%. And we compare that to what's published in the literature according to the other platforms. So CT-guided biopsy has a diagnostic yield of about 80%. And the non-robotic navigation bronchoscopy platform has a diagnostic yield of about 47%. So as you can see here, robotics actually does provide a much more superior diagnostic yield. So more than other platforms, we're now actually able to provide our patients a true diagnosis of what that nodule is, and really diagnose these very small lung cancers. These were some of the diagnoses that we've actually captured in our 195 patients over the last year. And I think the most significant part of this data is that 63% of our patients in the last year actually had a diagnosis of lung cancer. And 63% actually amounts to 123 patients. So in the last year, we've diagnosed 123 patients with lung cancer, which otherwise prior to this year probably would have not been diagnosed. So we think that is pretty huge. Our complication rate in our program remains very low. So we have a 2.5% lung collapse rate compared to 30% for CT guided. And we also have a 2.5% bleeding rate compared to 32% in CT guided as well. So not only are we able to have a higher diagnostic yield with this platform, we actually can offer patients a safer procedure with very, very low complication rates. So now that we have a robotic platform that can diagnose these lung cancers at smaller sizes and with higher accuracy, how does that sort of platform play into the overall pathway for lung cancer care? And so what we're going to talk about next is what we think is going to be the future of lung cancer care and really changing that pathway of lung cancer care to improve survival. And what we've launched here at Queens is a single anesthetic ion biopsy to resection pathway. And that opportunity is really shortening that time interval from diagnosis to resection for lung cancer patients. Now, taking a step back, time is important, and that time interval from diagnosis to treatment is really impactful. And there's a lot of numbers and words on this slide, but basically this is a study that demonstrated that a treatment delay, which was defined as the time interval from diagnosis to treatment of more than 8 weeks, in that group of patients, those patients were actually more likely to be upstage, so have higher advanced stages of lung cancer, had an increased 30-day mortality and a decreased median survival. So the bottom line of this study actually says that time is really important. And if we can shorten that time interval from diagnosis to treatment, we can really impact survival of lung cancer in our patients. So this is our traditional pathway for lung cancer care. A patient presents with a suspicious lung nodule that may have been found on a CT scan or maybe incidentally found. That nodule needs to be biopsied. And so traditionally we would do CT guided biopsy. To schedule that would take a couple of weeks. If the CT guided biopsy demonstrated a lung cancer diagnosis, then that patient would need to go to staging if it was appropriate. And that would often take another couple of weeks to sort of get that procedure scheduled. Now, if this was truly an early stage lung cancer, then that patient is a candidate for resection or to undergo a lobectomy, where we take out that part of the lobe of the lung with the cancer in it. And again, that also is going to take a couple of weeks to sort of arrange and schedule. Now, all in all, the traditional pathway actually takes anywhere between 5 to 6 weeks on a national average. In Hawaii, this pathway actually takes on average 8 to 10 weeks. And now if we go back to the other side and think about that time interval, anything over 8 weeks increases the probability that patients will be upstaged and decreases their survival. And so we may be losing a lot of our patients in Hawaii to advanced disease because of this traditional pathway and the amount of time it takes us to get through it. So we thought, well, what if there was a better way to sort of get through this pathway? And this is where our single anesthetic pathway comes into play. So on the side here, we see our traditional pathway, 5 to 6 weeks in total, 8 to 10 weeks in Hawaii. But now that same patient with a suspicious lung nodule on a CT scan comes to the operating room, and now we do our ion robotic navigational bronchoscopy. If that biopsy shows that it is a lung cancer, we actually don't wake that patient up. Then we'll continue to stage their lymph nodes when appropriate. And if their lymph nodes are negative for lung cancer or metastatic disease, then that patient truly has early stage lung cancer. And now we go straight to resection with a robotic lobectomy. So now we shrink that traditional pathway from 5 to 6 weeks or 8 to 10 weeks in Hawaii to now under 4 hours. So we launched our single anesthetic pathway at Queens in November 15, 2022, Lung Cancer Awareness Month, about exactly 1 year ago. I just realized that. Our ORs get pretty crowded because we have a lot of machinery. So we have our ion machine, our biopsy platform that's in the operating room. We use fluoro. We use fluoro for our adjunctive imaging. And then this is our endobronchial ultrasound biopsy tower that helps us with staging of the lymph nodes. Now, if that patient is truly an early stage lung cancer, then we move on to resection with our Da Vinci robot. So there's a lot of, sometimes it's like playing Tetris a bit with the operating room as we're moving machines in and out, but we get it done. Now, how this sort of rolls out and how this pathway rolls out in a clinical setting is let's talk about this patient's story. So there was a 79-year-old man who presented with a 1.7 centimeter right lower lobe lung nodule. He had a 50-pack-year history of smoking. This nodule was actually detected 2 years ago, and it was just monitored. At some point, there was an attempt at maybe a biopsy with CT guidance. However, it was actually aborted due to respiratory variation movement. So this gentleman was told just to continue monitoring because there was no other way of actually interrogating or investigating what this nodule truly was. So this was actually our first single anesthetic case, and he showed up at my clinic, and I reviewed his clinical findings, and then we went to the OR. And so first, we went ahead and did our ion robotic navigational bronchoscopy biopsy of this nodule, and it was actually positive for lung cancer. Then moved on to staging, and the lymph nodes were negative. And although this gentleman was walking around with his lung cancer for a few years, it was actually great that it had not spread to the lymph nodes yet. And so this was still deemed as an early stage lung cancer. And then we continued on, did not wake him up. And then we went on to do a robotic right lower lobectomy. His final pathology showed that this was actually a stage 1 lung cancer, and the patient went home from the hospital 2 days after surgery. So this is where we really feel like these single anesthetic procedures and this robotic technology that we have now is really impactful, because these patients that may be walking around with lung cancers and just had no options in interrogating them, now we can offer not only a diagnosis, but we can actually offer expedited treatment as well. And so over the last year, we've been really busy, and 21 patients thus far have gone through our single anesthetic pathway at Queens. And so 57% of those patients were women with a mean age of 71 years. Again, this is a November to November patient collection. About 62% of those actually underwent staging, where we biopsied the lymph nodes, and they were found to have early stage lung cancer. Our mean cancer size is 1.7 centimeters, which is actually quite small. And about 10% of those patients that underwent this pathway at some point in time underwent some sort of biopsy, which was either non-diagnostic or aborted. And so what we can see here is majority of our patients were Asian, and then we have about 20% of our patients that are Native Hawaiian and Pacific Islander. Most of our patients were former smokers. And then when we looked at the reasons why these patients had CT scans that demonstrated these nodules, it's really quite interesting, because about 38% of these patients actually their nodules were found incidentally, meaning they had a CT scan for some other reason, and it actually captured this lung nodule that popped up, and they actually now had a cancer diagnosis. The other group of patients here is the surveillance. Now, this is for cancer surveillance. So these are patients that have had cancer of any site. So any kind of cancer that underwent sort of imaging for their own cancer surveillance, and it demonstrated a pulmonary nodule. So 38% of our patients that underwent single anesthetic actually were positive for lung cancer. And that number, we're going to discuss why that's really important in the next few slides up ahead. So when we're talking about a new pathway to lung cancer care, we want to make sure that, first of all, it's safe and that it's comparable to sort of the outcomes that we have for our traditional pathway. So as you can see here, our procedure times are all under 5 hours on average with this pathway. Majority of our patients, about 2/3 of them, did undergo lobectomy, which is the standard of care for lung cancer surgery. About 1/3 of them actually underwent segmentectomy. So as we're now diagnosing smaller lung cancers, we actually now can provide patients lung sparing procedures. So segmentectomy is a cancer operation, but it takes out sort of the lung that has the cancer in it, and it sort of spares the good lung that the patient has, which is really important and impactful as far as their overall survival and recovery. When we look at our perioperative outcomes, our length of hospital stay is a mean of 2.8 days, and we have no 30-day readmission and no 30-day mortality, no conversion to open surgery. So all these patients stayed robotic, and a 13% prolonged air leak rate, which just means that the lung takes a little bit of time to heal. But all in all, these outcomes are actually pretty comparable to our traditional pathway outcomes. So although we're expediting the pathway, it is still deemed to be safe for the patients. Now, the other outcomes we have to look at are cancer outcomes, because if we're talking about a new pathway, we still want to make sure that we are upholding all the best practices of cancer care. And so about 81% of our patients had adenocarcinoma, which is a type of non-small cell lung cancer, and 14% had squamous cell, with one patient having carcinoid. Now, when we look at our pathway, majority of our patients, in fact, 20 out of 21 patients actually had early stage lung cancer, meaning resection was appropriate in them. In our one patient that had stage 3A disease, they actually had no nodal disease and was only upstaged because they had invasion into the chest wall. So based on this data, even though we're expediting the pathway, we are still upholding all the best practices of cancer care for lung cancer. So this is the value proposition that we feel is important for a new single anesthetic pathway for lung cancer care. It shortens the timeline from nodule identification to definitive therapy. And because of this, we may be able to stage shift now to earlier stages of lung cancer and actually improved outcomes and survival. It really does eliminate that high anxiety interval between diagnosis and resection. And when you talk to some of our patients on this pathway, a lot of them will say that they feel like they never actually had lung cancer because when they were diagnosed, they were sleeping, and when they woke up, it was treated and their lung cancer was gone. And so that's really huge for our patients. It enhances patient satisfaction with a comprehensive plan. There's a potential reduction in risk associated with multiple procedural and anesthesia events. And we are now able to actually maximize pulmonary lung sparing procedures. If we're diagnosing lung cancers at smaller sizes, we don't necessarily have to take out so much lung anymore. It decreases the impact on family resources. Our patients don't have to take off time from work to undergo multiple procedures for their lung cancer pathway. And it actually allows for an earlier return to employment and usual lifestyle for our patients. And we think that in the future, this may have the potential to actually have a decreased cost in overall lung cancer care without compromising oncologic standards. Now, these two programs that we have here at Queens are great and wonderful, and we're very excited about it, but we also know that we have more work to do. And as Pedro was saying earlier, in 2021 and 2022, and now in 2023, Hawaii does rank last in the country for early detection of lung cancer. So we still have a long ways to go. And these are some of the future sort of ideas and developments that we're hoping will come to fruition and change our last place ranking. So what are some of our next steps? So really, we want to now promote and increase lung cancer screening. And the main reason why is not only do we find that it is important, but now in Hawaii, we actually have a means of taking action when someone comes in with a positive lung cancer screening CT scan. When people get those lung cancer screening CTs and there's a suspicious nodule that comes about, they no longer just have to wait and watch or see if it gets bigger. We now can intervene and we can biopsy it with very high accuracy and very low complication rates. And so what is our current state of lung cancer screening? So right now, about 14.5 million people are actually eligible for lung cancer screening in the US. However, less than 6% of these high-risk individuals are currently being screened. In Hawaii, that number is actually less than 3%. And Hawaii ranks 40 out of 51 as far as screening utilization goes. And this is the 2023 state of lung cancer data. And so what are some of the barriers for lung cancer screening? Well, it's multifactorial. It's anywhere from patient education, but webinars like this is the first step to really empower our patients to take control of their own health and encourage them to go and get screened. Community services, identifying eligible patients. We need to overcome cultural barriers, medical record optimization, the ability for our medical records to start flagging high-risk patients, access to care. A lot of our patients won't get screened because they just can't afford to take time off of work. And then provider awareness, really having our frontline providers, our primary care physicians be out there and really be aggressive about the screening and offering screening. And why is lung cancer screening so important, and does it make a difference? Well, as we all know, lung cancer is the deadliest cancer for both men and women. And from 2014 to 2018, and the reason why we're picking these dates is because the first lung cancer screening guidelines came out in 2013. So 4 years after the first set of guidelines were out, we actually saw that stage 1 lung cancer cases increased by 3.9% per year, meaning early stage lung cancer cases increased, which is the direction that we want to go in. Median survival of patients actually increased at a yearly rate of almost 12%. And that's almost 3 times higher of a median survival rate than existed before we actually had screening guidelines. And so all in all, when you look at after 2013, when you look at sort of the data, it's actually estimated that 10,000 lives were actually saved because of the increase in early detection of lung cancers in the United States due to the 2013 guidelines. So who should get screened? Well, like I was saying, our guidelines first came out in 2013. However, the guidelines were then revised and reissued in 2021. Now, some of the differences between the 2 sets of guidelines is actually drop the age of the patient from 55 to 50 years old. So now we're capturing younger patients, and it actually decreased the number of pack years of smoking from 30 to 20. And so what this means is that our 2013 guidelines actually made 8.1 million people in the US eligible for lung cancer screening. And now with the decrease in age to a younger age of 50 and a decreased pack year history of smoking, we now increased our eligibility of patients to 14.5 million people in the United States. And what these changes in the guidelines actually did was it enabled us to have many more minorities and female smokers that are now eligible for lung cancer screening in the current guidelines that were not eligible before. So just to recap, who should get screened? If you are between 50 to 80 years old and you currently smoke or have quit smoking in the past 15 years and have a 20 pack year history of smoking, meaning to calculate that the number of packs of cigarettes smoked per day times the number of years smoked, you are eligible for lung cancer screening. And how is that done? So lung cancer screening is done with a low dose CT scan, not chest x-ray. So chest x-rays will only detect lung cancers once they're a certain size. And usually that size is above 3 centimeters. So by the time a patient has a lung cancer that's visible on chest x-ray, they're probably likely already more advanced. CT scans are much more specific, which is why that is the modality of choice for lung cancer screening. The patient lies on a table and an x-ray machine then uses a low dose amount of radiation to make essentially a detailed image of your lung to detect those really small cancers. The scan only takes a few minutes and is not painful at all. It's not invasive at all. And so how do I get screened? Well, ask your primary care physician today about lung cancer screening. Now, lung cancer screening has definitely been impactful of really helping us sort of increase the number of early stage lung cancers that we can now detect and treat. But where does screening not work? So screening does not actually work in 3 groups of patients. So the first one is minorities. We know that our minorities, especially our Native Hawaiians, are actually diagnosed with lung cancer at a younger age. Their mean age of lung cancer diagnosis is 45 years old. Now, the screening guidelines start at 50, which means that our Native Hawaiians are not screening in because they're getting lung cancer at a younger age. And we also know that when minorities have lung cancer, they actually have a higher mortality when compared to the general population. So even more so, we need to be able to really, really capture these early stage lung cancers in our minorities. The next population are women. So women are more likely to not have smoked or have smoked fewer cigarettes per day when compared to men. And therefore, many women actually fall short of the 20 pack year smoking requirement that is required for screening. So many of our women with lung cancer are actually not screening in. And we know that lung cancer screening is actually saving men, but it's not actually saving women at the same rate. The third population is cancer survivors. So I kind of alluded to this in our previous slide, but these are cancer survivors of any type of cancer. This is not specifically lung cancer, but any type of cancer. So we know that a patient that has had a history of cancer and is a cancer survivor is actually at higher risk of developing a primary lung cancer when compared to the general population. So 1 in 12 patients diagnosed with a common cancer of any site were actually later diagnosed with a second malignancy, with the most common being lung cancer. So where do we go from there? And that really is to improve our lung nodule detection. So in those 3 populations, minorities, women, and our cancer survivors, although they may not necessarily screen in, we also know that cancer screening guidelines are not going to change overnight. So what can we do here in Hawaii that can sort of offer early stage diagnosis and treatment to those 3 populations that may not necessarily screen in? So what we're really investigating here at Queen's is trying to figure out how we can improve lung nodule detection. And the opportunity is really to bridge the gap where lung cancer screening underestimates cancer risk in certain populations. And where we're going with this is artificial intelligence. So we know that artificial intelligence is probably going to be something in the future that's going to be very much implemented in the healthcare field. It is still relatively new, but we're actually investigating how artificial intelligence can actually help us in our lung cancer detection rates. And so we are actually one of the 2 pilot programs in the country that may be launching AI to help us with this. So basically, any patient in the Queen's healthcare system, and this is of course a model, but this is what we're working towards. So any patient in the Queen's healthcare system that gets scanned, whether it's an outpatient CT scan, an inpatient CT scan, or a scan in the emergency room for any reason, a radiologist will then read that scan and offer a report. Now that report then goes into an AI algorithm where the AI software actually identifies certain terminology in that radiologist's report that may be suspicious for a lung nodule, and then on a daily basis generates a patient list. So every day a patient list gets generated by this AI program that tells us these are the patients that got scanned in the last 24 hours that actually had a lung nodule detected on their CT scans. So we're hoping that although we can't change our screening guidelines overnight, that maybe by actually sort of thinking outside the box and implementing this strategy, we can now capture early stage lung cancers in those 3 populations that won't necessarily screen in: minorities, women, and cancer survivors. And so what we see here and what we are hoping is our vision for our AI and lung cancer is capturing those, of course, that do not screen in, and also the uninsured. We know the uninsured are not seeing PCPs on a regular basis, and they use the emergency room essentially for their primary care. And so those patients are getting CT scans, and now we can capture findings on those CT scans in the ER. And they're really, the thought is, and sort of the motto of this AI initiative is that we really want no nodule left behind, meaning we really want to be able to capture every single nodule that comes into our system so that we can evaluate that and detect those early stage lung cancers. And lastly, our next step is our lung nodule clinic. And so capturing all these nodules, increasing and encouraging lung cancer screening, what do we do with all these patients? Well, we want to form a centralized lung nodule clinic. And the opportunity here is to really expedite that lung nodule diagnosis. And we really want to identify, again, early stage cancers, but also offer patients a mechanism for follow-up for their lung nodules and not just sort of ignore it or have it fall through the cracks. And so this is what the nodule workflow looks like. We have a centralized lung nodule clinic, and that is staffed by pulmonologists, thoracic surgeons, and our interventional radiologists. And the inflow of patients would be from primary care physicians who may have patients that have lung nodules, screen detected nodules. So these are patients that underwent lung cancer screening that had a positive CT scan or positive screening. And then of course our AI nodule detection, which I had just spoken about. Now, these patients come into our lung nodule clinic. We have a where we can offer a multidisciplinary opinion. And then now we can take each patient's case and actually decide, well, what is the most appropriate workup for this patient, whether it's CT-guided biopsy, ion navigational robotic biopsy, or whether now we can go to the single anesthetic pathway where we're biopsying, staging, and treating cancers in one setting. And so we really feel like this clinic can not only decrease the redundancy of sort of, of the patient workflow, which sometimes when you have big healthcare systems, it happens commonly, but also expedite sort of that road from detection of lung nodule to treatment. And so basically we want to send the word out there that we actually have a home for your lung nodule. And if you have a lung nodule, let us know, because we have a place for you. And so what we hope that what our intention is with our lung nodule clinic is that we really want to offer a multidisciplinary perspective of the nodule management for our patients. Instead of the patient actually having to see 3 different specialists for that multidisciplinary opinion, we really want our patients to now come into one setting where now our healthcare providers are working together as a team with a patient-centered approach to offer that multidisciplinary opinion. We also want to expedite biopsies and treatment for these lung nodules and these early stage lung cancers that we will detect. And for those that may be too small for biopsy, we also want to offer follow-up and continued surveillance so that we continue to trend what these lung nodules look like. And if at any point in time that behavior changes where it starts looking suspicious, we can intervene very quickly. And so we're hoping to be live in our lung nodule clinic in 2024. And myself and Dr. Brad Takeshi, who will be partnering with me on this initiative, we're at the Queens Medical Center in POB 2. So that concludes my presentation. Thank you so much for your attention this morning. I'm be happy to, answer any kind of questions, but I just want to send 2 shout outs because I think they're on this webinar. So the first is to our Queens staff and our managers who honestly, like, our programs could really not come into fruition without the support of our staff there at Queens. And the second one is to my parents who help me take care of my children so I have time to do all of this meaningful, impactful work. So thank you very much. And I'm open for questions.
Thank you so much, Taryne. Every time that I hear you speak, I always get so moved, literally to tears, thinking about the amazing change that a single person can have in an entire community. There have been questions that have been coming in, so I'm going to go straight into them. Can you talk a little bit about the insurance model? Does private insurance pay for this? Does Medicare, Medicaid pay for robotic, for this type of robotic interventions?
Yes. So yes, and yes. Yes. Medicare is probably the easiest for us. Private insurance is, we have not had that much of an issue here in Hawaii. Once in a while, depending if a patient has one of the unusual carriers, it'll require like a peer-to-peer conversation. But I would say in my experiences, it's not very difficult to convince the insurance companies that this is definitely warranted and needed.
Oh, wonderful. And I know that you addressed this a little bit, but there's a question that came in that's asking, can we change the guidelines so that more people can be screened? Now, what I heard was that you're working at Queens to sort of change your internal guidelines, but you want to address that a little bit more?
Yes, I mean, 100%. I think the guidelines do need to change. I think we do need to definitely open it up. But oftentimes that's a huge national effort, and Pedro is very familiar about that. And when we're talking about national efforts, that definitely does not happen overnight. And so what we're trying to do is trying to figure out, well, while those changes and the data is being collected, where hopefully the next revision of our guidelines includes more people, we're trying to figure out, well, during the years that's going to take to, get that going, what we can do now. And so, these are like the AI program, our nodule clinic. These are some out of the box thinking strategies that we think that can actually help out those 3 populations of patients that actually don't screen in. And the other thing is data. I think everything is going to be data driven. So I'm hoping that as we sort of, continue on with these strategies, we are collecting data on all these things. And if we can actually show that, hey, like, this is our patient population is a bit different in Hawaii. And, these are the number of patients that are actually not being screened in. And if we can show that there is a big group, then that even helps us sort of push and validates our sort of our efforts into like changing those guidelines.
Thank you. Here's another question that came in. Can an X-ray detect something in the lungs to investigate further? I think you talked a little bit about how X-rays aren't necessarily what gives you that diagnosis. So what is the role of X-rays in all of this?
So chest X-rays are great. I mean, to some extent, chest X-rays, of course, are much cheaper than a CT scan. However, like I was saying before, really, like by the time a lung cancer is detected on a chest X-ray, it has to be actually a pretty large size in order for it to pick it up. And so patients that actually are coming in with chest X-rays with suspicious cancers, they're oftentimes advanced, meaning they're stage 2, stage 3s, and maybe even sometimes stage 4s. And the CT scan, it's just much more specific. And, when we talk about screening, we're trying to really increase the number of patients that have early stage lung cancer, because that is the population that we can actually offer treatments and surgeries for to actually go for a cure in that population.
So can you walk me through, this is a question that I had as you were going through the presentation. Can you walk me through, let's say somebody comes in, and it's amazing that it was about a year ago that you presented with the Lung Association and you talked about the setup of all of these things, and to see the outcomes that you have been able to produce here locally, it feels amazing. But can you walk me through what does it look like for a patient that has a persistent cough, or one of those simple symptoms that they might see their PCP, or as you mentioned that a huge chunk of them are not even seeing getting a CT scan for anything related to lung cancer. But what does it look like from that entry point into the medical system for something to the point that they see you? Who has to refer? How does that work?
So usually, our PCPs are our front lines, and we definitely depend on our PCPs to sort of to be knowledgeable about the services that we now have in Hawaii. I would say that's still a work in progress, just because we've only been around for a year. But I will tell you that from where we were a year ago to where we are now, we are really trying to get the word out there, and our PCPs are slowly sort of realizing that we have programs like this that exist now. And it's really about educating our primary care physicians that we actually now have a program. And what we really want to encourage our PCPs to do, because we know they're extremely busy, and we don't want to increase their workload, because we know they're already overworked and they see a ton of patients. And their work, I mean, we're very grateful for the work that they do. But what we want to do is we want to just provide a service that offloads them a bit. We want them to encourage lung cancer screening. We want them to go ahead and get the lung cancer screening CT scans, because if something pops up, if there is a potential cancer that pops up, we don't want them to kind of go through okay, well, now how do I get this patient to a specialist, or where do I need to send this patient? We want to make it easy for our PCPs. And that's why we have this lung nodule clinic, because now we're saying, go out there, screen everybody. If something pops up, don't worry about it. Send it to our clinic. We will take the next steps. We will make sure that patient sees all the specialists they need in one setting, not kind of ping-ponging around the healthcare system, and then figuring out what is the best pathway for this patient based on their scans. So we want the PCPs to go ahead and screen them. If they have a CT scan that shows a lung nodule for any other reason, no worries, just send them to our clinic and we will take it from there.
Thank you. We have time for one more question, and this comes from one of our board members, Julian Lipscher, who he wanted to know, and we know this, that this is not included in the guidelines, that people who are exposed for secondhand smoke are definitely at a higher risk for several lung diseases, including lung cancer, but are not typically screened or don't fall into the screening guidelines that are developed by the U.S. Preventive Services Task Force. what might be a way that this might be addressed in the future?
I think that's a great question. I think it's a question that all of us have sort of struggled to answer, because we know that it exists. We know that secondhand smoking is a risk factor. We see it all the time. Non-smoking patients that have lung cancer, and they sit in your clinic and they're like, how is this happening to me? I've never smoked. I've always had healthy habits. And then they realize, oh, their parents smoked, and maybe they had, secondhand exposure, for many years throughout their lives. We've seen it. Those are all anecdotal findings. Do we need to some sort of change our guidelines to incorporate our secondhand exposure patients? Absolutely. I think, groups like our early lung cancer task force, I think, is the appropriate setting, and hopefully I'm hoping that we can somehow, I don't know, collect the data, work as a team collectively out there, and try to figure out how we can expand the guidelines where we can now include secondhand smokers, or what is the data out there where if you have been exposed to secondhand smoke for this many years, then maybe now you should get screened too. But definitely a future direction that we have to explore more.
Well, thank you so much, Dr. Imai. It has been amazing. Like I said, I always love talking to you. That's not just being kind. I feel like such a geek getting into your slides always. So we thank you so much for being here today, and we thank you for all of your work that you're doing for Hawaii.
Thank you so much.
We'll move ahead with our next presenter. We thank Dr. Imai so much for everything that she has been able to do. Our next speaker is J.B. Smith, the Senior Biomarker Testing Executive at Genentech. J.B. is a genetic counselor by training. She currently supports equal access for all patients to guideline-recommended biomarker testing through education, awareness, and is a member of Genentech's biomarker testing team. She has spearheaded various educational initiatives, working with local thought leaders, including here in Hawaii, advocacy groups, healthcare systems, and reference laboratories. JB, thank you so much for joining us. I am going to turn things over to you. I am going to give you control of the screen, and I believe you should be able to take it away.
I think we're good to go. Thank you, Pedro, so much. And thank you for having me and giving me the opportunity to speak on this important topic. And I'm as inspired as you are about what Dr. Imai was talking about and the advances that are happening in Hawaii in early lung cancer detection. Let's see here. Okay, so I'm going to talk a little bit about biomarker testing and how that's really changing the landscape of the treatment side of lung cancer. And a little bit about my team. I am part of the biomarker testing team with Genentech, and we really work with we are multidisciplinary. We work with multidisciplinary teams in the communication of guideline-supported biomarker testing. And you're going to hear a lot about the multidisciplinary team. You heard Dr. Imai talk about that. And I'm sure everyone is aware that with lung cancer, it's complex, and there are many it's rapidly evolving, and that there are multiple departments and healthcare providers that need to work together and collaborate in order to provide the best care. We'll talk a lot about guidelines today as well, and how they're supported in biomarker in leading appropriate guideline biomarker testing, and some of the emerging biomarker testing opportunities as well. So some of this I'm going to go through a little bit quickly, because I think that you've heard that and over again, both from Pedro as he presented the local Hawaiian data, as well as from Dr. Imai. But what we do know, why is it so important, is because lung cancer remains one of the most common cancers. It also continues to be one of the deadliest cancers. And one of the reasons for that is that the majority of our patients are still being diagnosed and identified in late stage disease. And the earlier we can detect patients, the significantly the improvement in overall survival and long-term survival for patients. This particular slide here again just illustrates that even when we look at early stage disease, so even those patients that are diagnosed in early stage, early on, if you can have stage 1 or 2, you still have a reoccurrence rate. So 20% of patients, even in the earliest stage, may reoccur, but that more than doubles in patients that are diagnosed in a stage 3A. And for 5-year survival, again, the survival drops by more than half in those patients that are late early stage diagnosis. And this is important because we are getting more and more biomarkers and targeted therapies that are showing activity in early stage disease. So we can't continue to reiterate how important it is to identify our patients earlier. This slide, really what I wanted to illustrate by this is when we talk about biomarkers, we are starting to think about, and often you hear people talk about personalized medicine or precision healthcare, because we are looking at the actual genetic makeup of an individual's tumor and changes, molecular changes within that tumor, genetic changes that are driving that individual's cancer. And some of these happen at a relatively low incident rate or frequency rate, but combined, they're making up more than 64% of the patients that are being diagnosed with lung cancer today. So it's incredibly important. And within those 64% of patients that have an identified and actionable biomarker, there is a therapy that is available for them. And one of the things you also heard Dr. Imai say earlier is that in Hawaii, this becomes important because there are certain biomarkers like EGFR that we see at a higher frequency in the Native Hawaiian, Pacific Islanders, and Asian population, which are represented more commonly obviously in Hawaii. And so it's really important that we're doing these testings to make sure that we're identifying any of these biomarkers that we may see that may be happening at a higher incidence in Hawaii. On this slide, you'll see a timeline, and I think what's really critical, there's a lot of complexity. Not only did you see that there are multiple biomarkers that are associated with lung cancer from the previous slide, but the rate at which those biomarkers are being identified. This is still a relatively new field. The first biomarker being identified in 2005, and in 2021, there were 3 biomarkers that were identified in a single year, for example. And what we're also seeing is that we're starting to have these biomarkers identified in an earlier stage. So PD-L1 is now being indicated for early non-small cell lung cancer. EGFR is indicated for early non-small cell lung cancer, not just in late stage. So again, it's difficult for physicians often to keep up on what the latest guidelines are, what the current recommendations are because of the rapid pace of change that's occurring. Okay, this is a really busy slide, but it's really important when it comes to testing. And so I'm going to take a few minutes to go through this. If you look at the left side of the slide, you'll see the NCC and recommended, and you'll see the CAP, ISLAC, AMP recommendations. So NCCN is the National Comprehensive Cancer Network, and they do publish guidelines around testing and not only which biomarkers should be tested, but which methodologies of testing are appropriate. And as does CAP, ISLAC, and AMP. Those are 3 organizations that are pathology specific, cancer oncology specific. There's also ASCO guidelines. So I point this out because Even when we talk about guideline recommended testing, there are multiple organizations making recommendations, and those recommendations, as you can even see in this chart, don't always completely agree and align. And so again, adding to the complexity as a provider as to what your patient actually needs. Next, if you look across the top and you see actionable, it's important to understand that actionable means that there is an FDA approved targeted therapy that is available for those identified biomarkers that are listed below. So EGFR, ALK, ROS1, BRAF, RET, NTRK, MET, KRAS, PD-L1, HER2, those are all have targeted therapies. Those are must-test genes that all patients should be having with non-small cell lung cancer. And then we see moving to the right, predictive, and ALK, for example, is predictive in the early stage. And that means that we understand that there's a probability that patients will respond to a therapy. And then emerging in the treatment of cancer, we know that clinical trials are incredibly important for our patients, and many of the clinical trials today in cancer are being driven by some of these emerging biomarkers. So if we're not testing beyond our actionable, we may not identify some of the newer emerging biomarkers that would allow a patient to be eligible for a clinical trial. When we look inside this chart a little bit more, you'll see acronyms galore. And I think it's important to understand that these are all testing platforms. So many of the recommendations in lung cancer at this point are to test via NGS, which is next generation sequencing. And the reason for this is because this is a platform in identifying molecular rearrangements that has a tremendous amount of flexibility. Using NGS, you can utilize one tissue sample and you can test for anywhere from 100 to 500 to the entire genome with that single tissue sample. And you compare that to using some of the other methodologies, which would be like the PCR, polymerase chain reaction, or immunohistochemistry, or FISH, fluorescent in situ hybridization. If you're using those methodologies, you are doing a single gene test. So you are only testing for the ALK rearrangement, or you are only testing for the BRAF rearrangement. And so if you wanted to test for all 10 actionable biomarkers, would require 10 tissue samples, 10 individual tests. And most likely you would run out of tissue and you wouldn't have the time to complete those. And we're going to talk more about tissue and time in a bit as being major barriers to patients getting not only the testing, but the results that can ultimately lead to therapy. So it's NGS, you'll see, or next generation sequencing is the preferred method because it does allow for the broadest testing. And again, often you'll see these in panels, and different laboratories will offer different size panels. And so it's important also as a clinician to identify the correct panel for what that includes the biomarkers that you are most interested in identifying for the treatment of your patient. So time is something that I said we were going to talk a little bit more about. And one of the important, and Dr. Imai talked about time as well. Again, since most of the patients with lung cancer are not identified until late stage, an untreated stage 4 lung cancer patient has approximately 4 months. With treatment, with your traditional treatment like chemotherapy, perhaps an average of around 11 months. And with targeted therapy, we can see there's a significant improvement over even our traditional therapy. So we want to make sure that we're identifying those biomarkers, that we're giving patients the opportunity for targeted therapy when appropriate. But if it takes too long for patients to get results, they may have to start on a less effective treatment prior to getting results, just because time is critically important. This slide here is to show that we have that there are multiple major trials across multiple different biomarkers that have been completed that all are indicating improvement for patients when targeted therapy is initiated in overall survival and progression-free survival and overall response rates. So we see that across all the major biomarkers. And again, just reiterating the importance of providing the appropriate therapy when biomarkers have been detected, when the biomarkers are detected. In this graph, this is further evidence that when we looked at this study, looked at a little over 1,100 patients and divided in two arms, and in both arms, the patients received biomarker testing. They received next generation comprehensive genomic profiling. They were identified to have a driver mutation. And in the arm with the gold color, those patients had a mutation but received traditional chemotherapy, not the NCCN therapy that would be recommended. And you can see that the overall survival was less than when those patients were provided with the NCCN therapy. So again, identifying the oncogenic drivers and providing the actionable and targeted therapy that is appropriate, it does provide advantage in survival. So we did talk a little bit about time being an issue, and sometimes patients are they're sick, they need to go onto some type of a therapy, and a traditional therapy might be started prior to the results of your biomarker testing coming in. And in this trial, they looked at, this is a retrospective trial, and they looked at patients who received first-line targeted therapy, and the outcomes were the best. Median follow-up of 17 months versus 28 months for overall survival. But for some patients, a small cohort who started on traditional therapy first line, but when results came in, they were able to switch to the appropriate targeted therapy. Those patients, we saw no significant difference between the patients who started targeted therapy up front. So the opportunity to switch from traditional to targeted therapy when results come in does show that it still provides a benefit to patients versus those patients that were identified to have an oncogenic biomarker, but were never switched onto the appropriate therapy. So again, better outcomes were observed with upfront targeted therapy, but the opportunity to switch to that targeted therapy also provides a clinical benefit. So we know that lung cancer has significant implications for patients, high mortality rates, and we know that biomarkers are important, and providing actionable biomarkers are important for providing targeted therapies. And still a large percentage of our patients in this particular study in 2021, more than 34% of patients were not receiving NGS therapies or testing. So they were not likely to receive results on all the necessary biomarkers to be tested for. So why is that still happening? Well, there are a lot of barriers that are still in the way of patients accessing biomarker testing. This was where ISLAC looked at, which is excuse me, the International Association for the Study of Lung Cancer. They looked at barriers in the US and Canada, and the number one barrier was cost that was cited. I think in my experience, this is, we are making improvements here, but it's still one of the top concerns. Quality. And when we talk about quality, we're talking about tissue quality. So how much tissue is being received, how that tissue is being processed and managed from the time it is taken in a biopsy to the time that it is able to be evaluated and used is incredibly important. And we see poor quality, we see poor quantity being a big issue, where we don't get enough tissue to do all the full molecular studies that are required. Access is still one of the main barriers. More than 51% of patients are not getting access to the appropriate testing. Timing, 30% of respondents said they don't get their results back in a short enough time to act on those results. And then there's still a lack of awareness on what around the guidelines and what testing needs to be done. So this is a great, I think this is a great slide because it shows again to some of the complexity of the coordination that needs to happen in a multidisciplinary approach to getting the results, biomarker testing results. It starts with collecting the specimen. We just had a great presentation on new ways of collecting specimens, and that is a whole different disciplinary from collecting the specimen, then getting that specimen prepared properly by the pathologist, and the pathologist making the histologic diagnosis of lung cancer. And then there needs to be close coordination between the oncologist and the pathologist. What test is going to be ordered specifically? And often these tests aren't done locally. These tests are rare, are still relatively unique esoteric tests that are being done in reference labs. So those often need to be sent out. This can be a significant issue for Hawaii as well, because that often means sending those to the mainland, which can add to the time it takes to get results. And then conducting and interpreting those tests, as well as reviewing the lab reports. Along each one of these steps, there are gaps, and if those are not, if their processes aren't in place to seamlessly go between those, patients are lost. And what's interesting is that there are different institutions do these different steps. Some do certain steps very well, but have gaps. The gaps are different, is what I'm trying to say, from institution to institution. So it's really important to think about your own processes and your own institutions, and where you're doing things well and where there might be opportunities for improvement. And they won't be the same from institution to institution. And so it's important to really think about that for your own given situation and where you can make an impact for patients. The guidelines have actually, because time is so important, have broken these down into how long it should take, with a goal of 10 days from the time of specimen collection to the reviewing of the results and the ability to make treatment decisions. But these can vary from, we'll see varying from a goal of 10 days to 2 weeks to sometimes 3 weeks or even 4 weeks. So again, where are your institution? How often are you getting results back within a 10-day period? If not, where might there be delays? And this is a nice slide that shows kind of an average of time in each one of these steps. And this is, again, 170 clinicians were reviewed, and many of them, 37%, said it takes greater than 3 weeks. So back at one of the earlier slides, if you have a 4-month median survival, if you're untreated, and nearly a month is being taken just to get the results of a test to understand what therapy may be best, we need to do better. And many physicians, almost 50% of physicians, say they need to be able to make a treatment therapy decision within 2 weeks. So that's why it's imperative that we look at that turnaround time from specimen collection to treatment to report and therapy decision making, and where can we improve and how can we make those processes better. I won't spend too much time here, but I like this slide because it really shows and it reminds us that not only are these just processes, but this is a patient's journey, right? So this is a patient in the center of this, and each step along the way, that patient is that patient's tissue is encountering a different department, a different healthcare provider, a different segment for care, and that we have opportunities along that entire continuum to make improvements in the process so that we can ensure that that patient is going through as quickly and seamlessly as possible. So some of the challenges I think can be bucketed fairly succinctly. One is what we call, around tissue, QNS, so quantity not sufficient. So we're just not getting enough tissue. There's lots of reasons that can be the case. And how might we be able to approach that differently? There are some suggestions around that. The use of rapid on-site evaluation, or ROES, can often help ensure that there is enough tissue available in a biopsy to do the complete molecular testing. The other is to consider integration of a liquid biopsy pathway in your biomarker testing algorithms, and we'll talk a little bit about that in a moment. The other issue that we see, again, is the time it takes and the proper selection of the tests that are necessary. And this is something that we're really a multidisciplinary approach to the process, and perhaps development of reflex testing becomes critical, or a potential solution to improving that time that it takes. And then miscommunication, like you've seen now multiple times, there are lots of specialties, busy healthcare providers in different areas of the hospital and different labs, even in parts of the country, that will be part of this process. And so there has to be a real good and strong workflow to make sure that that communication is as effective as possible. I mentioned reflex pathways as a way to help with turnaround time, and this was a trial that looked at what happened when a reflex pathway was implemented, and three main things happened. One, the number of days that it took to get a result before there were reflex testing was 35 days. Once reflex pathway was implemented, that was cut in half to 15 days. And the other important change was that the number of patients that received the full comprehensive testing and NCCN guideline level went from 12% to 61%, so nearly a 50% increase. And there was also, just as importantly, nearly a 60% decrease in non-NCCN guideline recommended testing. So the implementation of molecular reflex testing pathway can improve the identification of targetable genetic alterations and the adherence to the testing recommendations. And most likely, one of the reasons for this is that this takes the entire multidisciplinary team will generally sit down and establish the parameters under which reflex testing takes place. So they're really optimizing the testing and allowing it to happen with as little ongoing communication as possible, because those pathways have been set up prior with the best process in place and the team making that decision. We talked a little bit about how liquid biopsy, and maybe many of you have heard about the incorporation of liquid biopsy into biomarker testing. So this looks at using both concurrent liquid and tissue. At this point, tissue remains the gold standard. It has the best sensitivity and the best specificity. What we see with liquid biopsy is that it has excellent sensitivity. If you do identify a mutation or a alteration in one of the biomarkers utilizing liquid biopsy, you can have a high degree of confidence that that exists and is real and act upon it. However, if you do not find a mutation, the sensitivity is not not as high as in tissue biopsy. So you may need to follow with a tissue biopsy. In this particular trial, they did concurrent testing where both tissue and liquid were looked at the same time. And you can see the increase in patients that were able to receive comprehensive testing when plasma was added, and also the number of patients that were able to receive first-line treatment with a targeted therapy when plasma was added at the same time as tissue. The testing results, the benefit are that obviously you're not dependent on the tissue, and the turnaround time is much more quick. So one of the concurrent, I don't see, it's ideal, but I don't see a lot of my accounts using concurrent, mainly because we see some reimbursement issues there. So often where liquid is added, it's added into a algorithm for your particular institution. So thinking where would liquid fit in, and putting that into the algorithm so that you are ready to pivot when or if you don't have enough tissue, for example, or if the turnaround time is something that is an issue within your institution, that you're able to make those pivots as necessary. Again, we talked about this to nauseam about how important it is to have this communication, but it is so vital that the surgeons, the pulmonologists, the interventional radiologists are talking to the oncologists and the nurses and the pathologists, and that we're putting the patient in the center so that we are able to put together the most effective processes and really being good stewards of tissue and time to get results for patients, because the addition of the targeted therapies is making a big difference and a significant impact on the patient's overall survival and other prognostic outcomes. So again, we talked, just to finalize, I know we're running short on time and I want to be able to open it up for any questions. So, I think biomarkers are emerging as an important indicator of therapy for patients, an important indicator of the prognosis of their disease, of how to manage disease over a period of time. And they are, impacting the majority of patients. 64% of lung cancer patients are found to have an actionable biomarker where they can benefit from some of these treatments. So thank you very much again for having me.
Thank you so much, JB. We really appreciate, I haven't started my video. Thank you so much. We really appreciate that you have been with us today. We are running very close to the end of the period. So I think maybe we'll have time for one quick answer, which is how are we doing as far as coverage, insurance coverage, both Medicaid, Medicare, as well as private insurance in Hawaii, if you know?
So coverage is often very dependent on the size of the panel, especially with commercial insurance. So Medicare and Medicaid will cover, and in Hawaii are covering quite well to guidelines. Commercial is a lot more variable. HSA has just recently added some good coverage for biomarker testing in more expanded panels, but it's important to always look at each of the individual, particularly in commercial insurance, and look to see where they're covering and the size of the panels that they're covering, because often that is one of the, if these panels are very large, sometimes they're not being covered as effectively.
Thank you so much. And we are right on time. We're on the last minute of this webinar. Thank you, JB. Thank you so much for being here.
Thank you, Pedro, very much.
Incredibly important conversation, and I'm sure we'll be having more with all of our local populations. So thank you. So we have come to the end of our presentations today. We would like to thank all of you who were able to attend, and those of you who'll be watching the presentation in the time to come. Our contact information is on screen. If you would like to follow up with any further questions, we'll be happy to pass them on to our presenters today. Also remember that the lung helpline can answer your most pressing lung health questions, including about any lung disease, including lung cancer. You can access the lung helpline by calling 1-800-LUNG-USA. We thank all of our speakers today, our sponsors, Aloha Care and Genentech, and all of you for watching. I'm Pedro Haro. Until next time, thank you.